All right, good afternoon, everyone. I think we're just about ready to get underway. GECO is hosted by the Gastro Foundation and Project ECHO in New Mexico. And as you know, it's at 4:30 every afternoon. If you want to stop, so there are two ways of interacting with us. You can use the chat box, but it's often quite difficult to monitor the chat box when you're busy talking. So if you do, if other people can also monitor the chat box, or you can just put your hand up or shout. I quite like shouting, especially there are not that many of us, there are 11, so it's happy for it to be a bit of a discussion. If you want to argue with me about something or raise a point or ask a question, then just go ahead, because I think we can make it quite nice and informal. So I'm going to start just giving a little bit of a talk that's based around a case. And then we've got another case, and they're both looking at various aspects of colon cancer. I think colon cancer is quite topical at the moment. There's a little bit that's changed over time, and I think there's a way that we can certainly, things are quite different for us in South Africa and Southern Africa than they are from where most of the literature comes out of, and perhaps we need to explore that a little bit more. I'm just going to share my screen. Karen, can you stop sharing your screen? And see if I can share.
Adam, I'm not sharing.
Well, I'm seeing something from you. Anyway, let's see if we can go here. Let's give us a second. My computer's getting a bit slow. It takes a while to cope with this. All right, Zubay, can you confirm you can see locally advanced colon cancer in an African context?
I can, Adam.
Okay, cool. Looks like it should look. Okay. All right, so I'm going to just go through a couple of things. Please, as I said, interrupt me as you go. So, certainly in South Africa, certainly in Cape Town, but I suspect for most of Africa, we've got a perception that we have advanced disease. We don't have much in the way of colon cancer outcomes. We don't have population-based screening, and we've got a limited resource. So the reality is that we've probably got disease that presents later with surgeons that aren't generally subspecialized, aren't just doing one thing. We don't have good streaming of patients. Most people are being seen by generalists. This graph on the right just shows when we looked at our APRs, just what the T staging was of APRs done at Laparoscopy. At one point, so we had 5 missing data, but the vast majority were T4s, and then there were T3s, and there were no T1s or T2s. Now, if you had to compare that data to European rectal cancer data, it'd be very, very different. So I'm going to talk about patient LM. He's a 46-year-old man. He's a mechanic, previously healthy, presents with large bowel obstruction. And I'm going to take you through the scan quickly. So we'll just have a look at it. And see, he's got a fairly full stomach. He's got some gallstones. He's got some dilated small bowel, a very dilated right colon. And I'll take it back to the whole CT scan because the whole CT scan isn't relevant. But if we just come back to there, most of you can see a mass over there. And it's sort of gone around there, quite a lot of inflammatory stranding around there and those gallstones. Okay, so the first thing we need to look at is how good is CT scan at picking up how advanced a colon cancer is. And if you look at it, comparing T1 and T2s to T3s and T4s, sensitivity of 86% and a specificity of 78%. But I mean, that's not like all that brilliant. If you think about, like, T1 to T2 compared to a T3 and a T4, that's a fairly substantial difference. Nodal disease, pretty much the same, but as far as specificity is concerned, around a quarter of the time. And that's when Gina Brown writes it up, and she's probably the best that there is. Okay. So if you look at right-sided colon cancer, in 18% of cases, the radiologist couldn't identify the tumor. A little bit alarming, really. CT scan overstaged in 23% and understaged in 48%. So we're only correct in about 30% of cases. And that's just for the T staging. Nodal disease, very similar. So clearly not very good at it. If we look at our experience, Kunle Oki, who was a fellow with us, wrote up a series of patients that we did a multivisceral resection on. And if the total cohort, 158 patients were called T4. Only 44 patients required multivisceral resection, and only a third of those were actually T4Bs. So, if you think you've probably got 12 patients who actually had invasion of another organ called, but 158 were called on CT scan. So we're clearly not very good at identifying who are T4 cases. Anyway, coming back to our patient, he had bowel obstruction quite clearly. He wasn't passing flatus or stool at all, and he was taken to theatre on the back of that CT scan, which showed no metastatic disease. And at laparotomy, a senior surgeon was called. The tumor was deemed to be irresectable, invading the head of the pancreas and the stomach, and a palliative cecostomy was performed. The patient was brought to the MDT for palliative chemotherapy. He was doing well, really, since he'd been defunctioned. His symptoms of the last couple of months had disappeared. And he was obviously being young, well, not like everyone, wanted to live, didn't want to die, wasn't ready to yet. And we had a discussion with the primary surgeon who said, look, the procedure, when he took the patient to theatre, the patient had this very distended bowel. It was very difficult, but it seemed fixed in the middle. But he couldn't say with absolute certainty that it was irresectable because he hadn't done a dissection on the structures that would make it irresectable. But the feeling at the time, he certainly couldn't take it down under those circumstances. So we did a gastroscopy to see if there was invasion into the duodenum, which there wasn't. And he was given 4 cycles of Folfox and a PET scan and CT prior to trial resection. So this was really based on the basis of this study, which came out in the Lancet in 2012, essentially a randomized controlled trial of 150 patients, so 2-to-1 randomization. So you ended up with 100 patients that were given the intervention, which was neoadjuvant chemotherapy, versus 50 that weren't. Okay, and they included all patients with a T3 that invaded more than 5 millimeters or T4 lesions. They had no difference in the postoperative complications, and the apical node involvement in the resected specimen was 1 out of 98 versus 10 out of 50, and the resection margin involvement 4 out of 99 versus 10 out of 50. So they got an R0 in significantly more patients, and the apical node wasn't involved in significantly less if you gave neoadjuvant chemotherapy. And that's really very exciting. The problem is that that was in 2012, and that was the trial. They went on to randomize a whole lot of patients, and 2 years ago that data was presented at a national congress, but still hasn't been published. This is what I could get off the internet. So then they were doing 600, so by this stage they had 698 in the intervention arm versus 354 in the non-intervention arm. And they got a significantly better R0 rate, 5% versus 10%, okay? So, well, 5% had an R1 or R2, or 10%, and a pathological complete response in 4%. These don't P and end stage, not that much. Complication, prolonged postoperative stay, was more or less the same. So you didn't have more complications and you didn't have more anastomotic leaks. In fact, they appeared to have more anastomotic leaks, but it wasn't statistically significant. However, if we look at the 2-year relapse rate, it was very much the same. So with this study, this is now conference data. It has not been published yet. I can't give you very great detail on it. What they managed to do with neoadjuvant chemotherapy is increase the R0 resection rate, but they did not manage to improve disease-free survival. Okay. So that's but it's only 2-year data, and you wouldn't really expect to see that outcome at 2 years. And so hopefully when you get 5-year data, that R0 resection rate should translate into disease-free survival benefit, or will it? We don't know. But certainly quite encouraging, and to think that they included T3 lesions and nodal disease. And I must say, to me, intuitively, where you're going to want this, if your benefit is an R0 resection, you want to include patients that the resection margin is threatened. So really, I'm looking at patients that have got an involved margin more. So, perhaps you want to be looking more to the patients that are going to benefit the most, to the T4 lesions, but we can't say that at this stage. So this was another study done, just showing that, and it's a 26, it's basically a propensity score match study, and essentially they showed increased 23% lower risk of death if they received neoadjuvant chemotherapy. Now, I don't entirely trust neoadjuvant chemotherapy because I never quite understand it that well. So I mean, not neoadjuvant chemotherapy, I never trust propensity match scores, because I'm kind of, to me, it seems a little bit like statistical skullduggery. You only match the things on the things you know about, not the things you don't know about. But nevertheless, it's something to add to the benefit. There have been 3 systematic reviews published in the last 2 years, all of which showed some benefit, but all enrolled lots of studies that, I mean, there's only been one major randomized controlled study, which was Foxtrot, which was only the one in 2012 that I showed you. Those results have been published. So, I think getting a whole lot of single-arm studies that aren't even propensity score matched, and then doing 3 meta-analyses of it as a new study comes out, doesn't really change the outcome. You just mostly garbage in and garbage out. Okay. So this is our patient after he had his neoadjuvant chemotherapy. Let's play that quickly. Still got gallstones, unsurprisingly. You'll see there's a lot less mesenteric stranding around here, and you can see the tumor a lot more clearly now, but without that sort of peritumoral inflammation they had. And if I just take you back to some of the critical structures here. Oh, sorry. So we're coming down here. So we're just looking head of pancreas is, which we're not seeing very well at all, but I think we can't clearly see any major involvement apart from quite obvious involvement of the stomach. Okay. So I can't say that we've shrunk this tumor massively, but I think what we can say is that there's certainly much less stranding, and the sort of inflammatory response around that is much less, which is going to presumably make a dissection a lot easier, knowing where the planes are. So if we look at multivisceral resection at Laparoscopy, this is the same group of patients, an article by Quinley. We got an R0 in 74% of cases, and a 5-year disease-free survival of 45%, and an overall survival of 55%, which kind of matches what you'd expect internationally. In fact, not bad results, seeing as we've got FOLFOX, and we didn't have oxaliplatin for the entire period of the study, only for some of it. And we certainly don't have any access to any of the biologics, which is what you're sort of competing with in results. So what do we know at this stage? there's an incidence of T4Bs without distant metastases. You do get this group of patients. I've often thought that, if you get really big tumors that invade locally and you don't have metastases, what you've got is someone who's got a slowly growing tumor that hasn't noticed, hasn't become symptomatic. And the fact that they haven't metastasized now is almost a good prognostic sign. I think a big tumor without metastases tells you that in a way it's a kind of failed tumor. If you've managed to get that big without metastasizing, you're not really a very good cancer. In our series, 3.1% of patients with T4Bs. What we do know across the board is that if you can, to get a long-term survival, you need to do an R0 resection. And even if only 34 to 70% of the tumor's adherence is truly a T4B cancer, the separation between the tumor and the adjacent organ compromises oncological results and makes local recurrence, increases local recurrence and a poorer 5-year survival rate. So I think, that's kind of really the case for neoadjuvant therapy. I just want to talk about some other aspects of colorectal cancer as we might see it as advanced colorectal cancer. So I always find this paper quite entertaining. Right hemicolectomy plus pancreatic duodenectomy versus partial duodenectomy in treatment of locally advanced right colon cancers, invading the pancreas or duodenum only. So they did a systematic review basically of 50 of basically patients with invasion to that area. 39 were treated with an unblocked Whipple's, 10 partial duodenectomy and pedicle ileal flap, and 4 with direct suture. And if you do, the bigger the procedure, the better the results. Look, I think this is all retrospective trolling of data, but I do think if you look at the 52% 5-year survival rate, if you've got a right colon cancer invading the pancreas, that's probably your best indication for a Whipple's, because that's pretty good 5-year survival data for any Whipple's. If you look at a paper looking at laparoscopic surgery for T4 colon cancer, it's a systematic review of it again, and the conclusion on laparoscopic surgery for T4 is restricted to non-randomized comparisons with substantial allocation bias, and for T4A might be safe, whereas T4B requiring multivisceral resection should be applied with caution. I mean, intuitively, I don't think there's a major problem. If you want to go in laparoscopically and take off the peritoneal sidewall, that's fine. There's a bit of small bowel knotted into it. You've got a bit of terminal ileum pulled into your right side of cancer. Well, I don't think there's a reason why you shouldn't do it laparoscopically. But I think the moment you start, having doubts and trying to work out where is the mark of your cancer, then you've got to be very careful, because I think, you've lost your sense of touch. You can't feel what's thick and what's thin. And now you're going out of plane and then trying to get back into plane. It can be done, but it's not the easiest thing to do. So I think it's horses for courses. What are your skills? And, where is it invading? Are you worried about vessels? Then you probably want to be doing it open. Is it just a bit of abdominal wall? That's simple enough to do. But a small bowel, simple enough to do. The other thing that we see fairly regularly is perforation of cancers. And if you look at the survival, if you've got a contained perf versus a free perf, you've got a big difference in survival. And, that's fairly obvious. If you have a free perforation, you're going to do significantly worse. But I think that if you look at patients that have a perforation, intuitively to me, and I don't think there's any data to back this up, if you've got a patient with an abscess, in that abscess cavity theoretically are cancer cells. If you operate on that patient emergently, you're going to operate in the abscess cavity. You're then going to have spilts, tumor cells throughout the abdomen. Whereas if you can percutaneously drain that abscess cavity, cut out your drainage tract at a later date when the patient is stabilized, and then do an en-bloc resection, you're going to operate outside where the abscess cavity was, and your chance of actually getting an en-bloc resection and avoiding local recurrence, to me, intuitively seems much higher. So that's really been our practice, that if we've got a perforated cancer with a with an abscess, we'll perk drain that abscess. If there's any obstruction, we'll bring out a stoma perhaps, but you don't always need to bring out a stoma, and sometimes we'll stent the patient. But I think, and then come back later and do a more radical operation, perhaps after chemotherapy. So I think, if you're doing these advanced tumors, you've got to have a couple of tricks up your sleeve. And I think laparoscopic surgery has taught us all to do a medial to lateral dissection, and doing a combination of going from medial to lateral and from lateral to medial, and slowly getting to the point where the tumor is most advanced. Because what you want to do is you want to be able to pull out when you realize that this is actually irresectable. So you don't want to do you don't want to be taking vessels, you don't want to be doing anything that commits you until you've got as much information as you can get. So you want to do as much of your dissection without committing. So you're not transecting bowel early, you're not taking vessels early. But once you know you're going to go ahead, then I find it often quite difficult to staple off the ends of the bowels and get everything up as much, and do that very last bit of the dissection under direct vision. I like, if it's in the pelvis, I like ureteric stents. They make me feel safe. And even if it's just because I know when I've cut the ureter, I think that's very useful. But Professor Goldberg, who trained me, doesn't like ureteric stents. He thinks they're a waste of time. I've had complications from ureteric stents. We've perforated a ureter with a stent, and we've caused a false aneurysm in the kidney with a stent. So they're not without their danger. They do add some time. But on balance, I think they're probably useful. Urine and poo, not a great combination. I think that if you're doing a complex bladder repair, I generally want to bring out a stoma. But if there's just a bladder leak, small thing, and I can separate it, get a mentum between the two, a small hole in the bladder, I think it's perfectly reasonable to go ahead and do a primary repair. But the moment you're doing Bari flaps or something like that, with anastomosis nearby, you have to accept that all urinary anastomoses leak a bit of urine. And it's not a problem for the urologist if they've got a drain nearby. But if you've got an anastomosis nearby, it's a very, very big problem. And I have the same prejudice against bile, which also leaks straight into your anastomosis. I think if you've got a patient that looks like they've got peritoneal mets, and you intraoperatively, you have to biopsy those peritoneal mets. I've had a number of cases that have come to me with query peritoneal mets, no biopsy, you then committed to go back in, and often they aren't. We're not that good at telling if they're peritoneal mets. Now, sometimes you might not have frozen section available to you, but you have to biopsy them. You cannot take someone who's got peritoneal, who you think has got peritoneal mets, and not biopsy them. You have to have histological proof of those mets. If you decide you're going to do a stoma, the only place for a Hartmann's is in the sigmoid or the rectum. The rest of the time, you can bring the other end up to the skin. And a double-barreled stoma is a much smaller procedure to close than doing a laparotomy to go and bring out the end of the transverse colon that someone's done a chop and drop just because they can't be bothered to bring it out through the same hole. It's not a South African phenomenon. It happens all over the world. But we've got this sort of thing of dropping the other end into the abdomen where it can leak, bring it to the skin, and you can almost always bring it out the same hole. Okay. And as I said before, we perk drain perforations of cancer and resect electively, and I think we've had, anecdotally reasonable results with that. I think questions that one needs to ask perhaps is, does one need to harvest lymph nodes in the invaded organ? So you've got some small bowel that's involved. Do you have to do a lymphadenectomy in the small bowel? If the gallbladder is invaded, do you have to do a lymphadenectomy of the gallbladder, wherever those nodes might be? I haven't the faintest idea. I don't know the answer to that, and it's not something we've routinely done. The role of laparoscopy, firstly, looking for metastases. I think sometimes in these big tumors, put in a laparoscope and I'm sort of not that keen on complex laparoscopic operation. I think colorectal laparoscopic surgery is complex enough without adding other organs that you want to remove. The role of chemo, I certainly don't think we've proven the case for neoadjuvant chemotherapy. It's a very attractive option, often buys us time. And even if it's just selecting out the patients that respond, at least you're picking good biology. And so I think the sort of case for bailing out early or given chemo early to see how does the patient respond means you're probably going to operate on people who are more likely to benefit. The management of perforation with an abscess, I think it'd be lovely to get a multi-center study going, because there is one paper on it with 29 cases. I'm sure we could get more than that in South Africa in a couple of weeks, well, maybe years. Okay, so we can't be certain that we have more advanced disease in Southern Africa, but it is likely. I think it's interesting to know that, you know, if you're in one of those situations where you've got an 80-year-old on the table and there's an adhesion of the tumor to some bowel, and you really don't want to do another anastomosis. Patient's not in good condition. You were going to do a Hartmann's for your sigmoid cancer, and now it's adhered to some small bowel. Well, if you dissect it off, you'll only be getting an R0 in a third of cases. Now, obviously, there's some that are obviously involved, but there are others where it's a bit more questionable. And I think there's the odd case where you might think, on balance, I'm going to dissect it off. Patient's elderly, and anastomosis is huge in an elderly person, and I'm not gambling with as many life years. Staging certainly needs to improve in South Africa. Our radiologists didn't do very well in our study, but in the world, they haven't done particularly well. And neoadjuvant chemo looks promising, but it's not a done deal yet. I do think that radical resection is something that we as surgeons in Southern Africa have to get used to doing, because I think generally you're looking at tumors with a good biology. Okay, so I think I'll stop sharing for the moment. We can see if there are any questions. I haven't been able to monitor the chat at all, which is good because there's been nothing going on in it. Are there any questions from anyone? Anyone with any experience in doing this? Anyone who thinks it's all garbage?
Adam, so can I just ask, it's Gert van der Merwe here from Bloemfontein. So if you open up a cancer and there's any sort of adhesions in the area, do you always regard that as, or manage it as tumor infiltration?
No, I mean, if you've got your mass and your mass is clearly stuck onto something, then I will manage that as tumor infiltration. But as I said, not always, because sometimes I'll say, well, on balance, this is going to make the operation much bigger, a much bigger outing. I don't think the risk benefit is worth it, because the patient's frail, the patient's not going to manage an anastomosis, or the patient won't manage a proximal stoma. And then I'll see if it's a borderline case, maybe we can dissect it off. But I mean, as a surgical principle, if you have an adhesion onto a cancer, you have to take that organ en bloc. So that's the correct answer. But we know from our study and other studies that that we can't be certain that, you know, just because it's stuck, it's not always cancer adhesion. You do get sort of inflammatory adhesions on it. So I think it's, you know, am I answering your question?
Yes, thank you.
Anything else from anyone? We do have another case to go through, which Zubair Salih is going to present, but it's on a slightly different angle, but they do all come together. So perhaps we should go on with Zubair's case and then have a bit of a discussion around it in general. Zubair, are you ready to go?
Yeah, I'll just share my screen quickly.
Okay.
Can you see it, Adam?
I can see it. Yeah.
Okay, cool. Good afternoon. Sorry, I'll be presenting on behalf of my colleague who's currently tied up. So the patient that we have is a 72-year-old female, Mrs. F. She's known with reflux disease on PPIs for the last 2 years. She's also got quite a significant smoking history. However, she does have a good baseline of a performance status 1. She initially presented to the physicians complaining of this epigastric pain, was radiating to the chest, also had a little bit of shortness of breath on mild exertion, and she always just generally felt tired and weak. She also complained of diarrhea and vomiting, with approximately 5 kilos of weight loss over the past 6 months. She's got no other surgical history of note, and she has a family history suggestive of breast and colon CA. So on examination, she looked generally well. She had some mild pallor, which we can attribute. And then she had some weight. She weighed currently at 55 kilos with a BMI of 20. On abdominal examination, she was a bit distended, but not overtly. She had some fullness in the right upper quadrant. Whether this was the liver that was palpable or palpable mass was questionable. She had no surgical scars, and she had a normal rectal examination. These were the bloods that was done on admission. She had an HB of about 9.9, an MCV of 59, and platelets of 571. She had a normal UEC after an acute kidney injury and the initial bloods, and then she had an albumin of 35, and her iron was found to be 2.4, transferrin at 1.9, and SATs of 5% only. And the trops were completely normal at the time. And they proceeded to do some imaging, of which they did a erect abdominal X-ray, of which we have a very non-specific X-ray, and I'm not sure if you can actually see anything specifically, but to me, it looks like there's absolutely nothing really we want to see as what we're finding clinically and on abdominal examination. So we then proceeded to do a G-scope focus. She had the vomiting and she was known with peptic ulcer disease. She had a normal scope all the way down till D2, and they proceeded then to do a CT abdomen. So I'll just take you quickly through the CT. So she had a CT, this was the base of the chest, which was normal, and she had a CT going down to the abdomen. The heart was also normal. There was no calcified vessels to suggest anything sinister. And then she had the CT of the abdomen, of which we can see these multiple hyperdense lesions in the liver. That's the stomach that's mildly distended. And then as you come along, I'm just going to go a little bit forward first before I come back. You can see that the right side of the colon is dilated, and there's not much dilated small bowel loops, but a massively dilated right-sided colon. So if I come back on the CT, I think you can appreciate that there's quite a circumference. Oh, sorry. So there's quite a circumferential mass that's sitting right just past the hepatic flexure that was noted and was thought to be malignant of nature. The rest of the CT was normal. There was no hydronephrosis. There was a right-sided renal cyst, and everything else was okay. If you go through the CT again on imaging, it didn't look like it was adhered to any other structures locally. So in summary, we've got a 72-year-old female with a good performance status, no other known comorbidities. She's a smoker with an acute kidney injury that has resolved, now presenting with an obstructive colonic lesion, of which we have no histology on at this point. The report had suggested the liver lesions are benign with a suspicious lung nodule that was present. So the plan was then what to do with her next. And we had various opinions at the time.
So
yes.
Can we stop you there? Why don't you, have you got any more slides after this? Was that it?
No, that is it.
Yeah, good. So do you want to stop sharing and let's get some opinions as to what we should do?
Okay, 1 second. Sorry.
I'm just going to randomly pick on some people who I might know or not. So let's assume for the moment that those cystic lesions in the liver are benign. You've got a patient with 5 kilograms of weight loss, smoking history, and some shortness of breath and exertion. James, what would you do in this situation? A fairly common situation, I'm sure we've all been in it.
Yeah, the two problems, one is the patient's obstructed, and two, that you don't actually have histology yet.
Yeah.
So
Okay.
the two ways of dealing with that, either colonoscopy and stent and then get histology at the same time, but I think that would be difficult in this patient, or operate and resect and get histology and overcome the obstruction at the same time that way. So personally, I'd probably operate.
Yeah, okay. And what are you going to do as an operation? So you're going to do the resection, right hemicolectomy, anastomosis, or
I think
not?
In this case, extended right, I wouldn't do an anastomosis personally, because if I distended that bowel is, I know some people would. And then, yeah, wait for histology. We would probably do MRI liver with Primovis to see if those truly were benign looking liver lesions. You could also look at them intraoperatively and then go from there.
Yeah, but realistically, you've got to, well, I don't know about your setting, but for us to get a Primovis MRI is going to take, a little bit longer than 48 hours generally. So we kind of, I mean, generally one doesn't need to operate on these patients immediately. You've usually got a little bit of time, but we wouldn't usually be able to get a Primovis MRI beforehand. Gert, what would you do?
So for me, I think I'll accept your comment to say that we accept that those lesions in the liver are benign. So from that standpoint, I would also offer the two options that James presented, but I would also throw in another option of just doing a proximal stoma. The issue there is that your ascending colon is obstructed, and ileostomy is not going to decompress your cecum. So that's a bit of a difficult one. Cecostomy, as we know, is not a great stoma. However, it is an option that could be considered in terms of temporizing things and sorting out your patient completely and trying to get to a better, more definitive plan in terms of your oncology management.
Right. So, I mean, we've got three options on the table now. The problem with patients is you generally only do one option on them at a time anyway. So we've got a stent, a stoma, and a resection anastomosis. Is anyone here going to do a resection a resection without anastomosis? Is anyone here going to do a resection with an anastomosis? Anyone?
Hi, Adam, it's Phil. Our case was cancelled, so I made it to the talk.
Yeah.
So I actually was managing this lady, and I was technically going to operate on her, and I was very much planning on anastomosing her.
Okay. So, I mean, James raised an issue about, well, the bowel's dilated. So, I mean, there is data on anastomosing. I don't remember the study just done in the UK on doing right hemicolectomy and primary anastomosis and right-sided colonic obstruction, which showed as good a results as patients with an elective hemicolectomy. Now, one has to say that we all know that can't possibly be true if we look at the patients that we see with bowel obstruction. And I think where you start running into problems, there's a difference between someone who's got bowel obstruction and a slightly dilated bowel and someone who's been obstructed for 7 days. We often see patients who've been obstructed for 7 days, and I think it's a very different thing. And so that's where judgment comes in. But, you can do some slightly dilated small bowel, makes it a bit easier to anastomose to a normal sized colon. So in the right patient, I think it's completely reasonable to do a right hemicolectomy and primary anastomosis, without a doubt. Whether this is the right patient, I'm not entirely sure. 5 kilograms of weight loss. We're quite serious about weight loss as a percentage of body weight. So it's just on 10%. But, I mean, if you think every Whipples that's ever been done, someone said they've all had 10% weight loss just about, and they managed to get some of them through briefly. So I think that you can't be too fixated about 10%. I mean, every second person's a smoker and short of breath and exertion. Well, I mean, she's got a very distended stomach. She will be a bit short of breath when she exerts. The best way to sort that out is to decompress her stomach. So there are 4 options on the table. And I think that's essentially what you've got to look at is what are you targeting in this patient?
I think, Adam, also, when you look at this lady's scan, as much as, am I still on? Yes. As much as she was distended, her small bowel wasn't like that massively distended. You get that small bowel that you're like, this looks horrible. I'm not going to join this to anything.
But it's certainly a distended small bowel on that. I mean, you can see why you're not seeing it on the x-rays, because on the x-rays, it's full of fluid, but on the CT scan, the loops are fuller than they should be. There's definitely small bowel obstruction, but I get what you mean. This isn't someone who's been obstructed for weeks and weeks, and this isn't, like really all that bad. So firstly, let's just look at it. What's the advantage of a stent? So we'd be looking at not a palliative stent in this stage, we're looking at a bridge to surgery stent. And so bridge to surgery stent, the big advantage is you avoid a stoma. So it was, the whole thing was designed for the left side, and you've got a left-sided tumor, you get a stent, you come back in a couple of weeks' time and do an elective resection, avoiding a stoma. No one's ever tried to suggest that there's a survival benefit about stenting. I think there might be, but we can come to that. So essentially then what happened was people said, well, there definitely was a benefit as far as avoiding stomas were concerned. But was there manipulating this tumor, is there harm? And what was happening is, I think in Europe, when they were stenting the patients, when they went to go and operate on them, they were finding at the oral end of the stent, it had eroded through the bowel and there were abscesses there in a sort of 14% or something of it. And the concern was you'd taken a T3 lesion or T4A and converted it to a T4B. You'd perforated the cancer. And there were some studies done looking at kind of messenger RNA or one of the DNA sequencing of tumor cells in the blood at the time of doing a stent. And they found there was like showers of cancer cells going into the bloodstream. And so all of a sudden, there was this perception that we were worsening the oncological outcome by doing a bridge to surgery stent. But they've never actually demonstrated a worsened outcome. But there were these abscesses, there were these tumor cells in the bloodstream and things like that. And perforations at the time, either actually just perforating the tumor with guide wire, which is clearly very worrying. And the benefits of the stenting were not great. They were just a stoma. But if you look at those studies, their indication for a stent was unable to pass a colonoscope. And what most of you'll know have done in the endoscopy is you quite regularly scope asymptomatic patients or very mildly symptomatic patients, and you can't pass the colonoscope past the tumor. And actually the patients have no symptoms of bowel obstruction at all on that grounds. Peter Tannis went back and looked at it. He's from Holland and looked at it, and they actually went and looked back at the patients done in the randomized controlled trials and actually pulled out just the patients that actually truly had bowel obstruction on CT scan. And they did a propensity score match study on those, showing that there was no harm done to the patients from an oncological point of view. So there've been quite a lot of kind of data now collecting, showing that oncologically perhaps there isn't harm done, but the reality is you need quite long-term outcomes before you can say that you get at least an oncologically equal result. And the CREST study, which was a sort of pragmatic study done based in the UK, the colorectal stenting trial, CREST, and that's got early outcomes are good, but we're still waiting for the 5-year outcomes because that's really what you need before you can fit oncologically safe. But the pendulum that went away from, so first we had stenting came in and we stented everything. Bridge to surgery was in, then it was out, and now it's slowly coming back. And I think we're sort of at a point at the moment where it's probably acceptable. But you have to understand that perhaps you're worrying about, you might lose a bit on oncology, but what you gain in morbidity, because what you're probably not picking up in the European studies is the classic South African or African bowel obstruction, which is someone who you do the midline laparotomy, and the first thing that happens is the cecum pops out and starts tearing in front of you. You then spend the rest of the operation wading through distended bowel as you try and find the tumor, and the whole experience is intensely miserable for the entire theatre team, not to mention the patient. And those patients do very badly. We're busy looking at that at the moment in Cape Town, but it does, I think the morbidity and mortality associated with large bowel obstruction is extremely high. And provisional data from our series looks like in the region of 25%, which is really appalling. In which case, we should never be operating on patients with large bowel obstruction with a curative intent. We should be doing a staged procedure every time. So I think what you've got to weigh up with stenting is it makes your operation easier. You might avoid a stoma versus you might affect the oncological outcome. And that's different for each patient. So if you've got a 35-year-old patient, oncology is everything. If they're fit and healthy, they're probably going to cope. You're probably not going to stent them, even though they're the ones that really don't want a stoma. There you want to make sure, oncology is king at that point. Now you want to really look after that cancer and you'll cope with the complications. When you've got a 78-year-old, you want to do the safest procedure, okay? And oncology really, it's important, but it's not the most important thing now. You've got to get the patient through the operation for them to get the benefit of an oncologically safe operation. And then one's got to look at how patients feel about colostomy and their perception of risk, because that's something that is a lifestyle thing. And it varies from patient to patient. Some people are very against it, some people aren't. So I think that's the stent versus resection and anastomosis. Then you've got resection and stoma, which is a sort of halfway house. So now you're still going to get a lot of the physiological insult of a big operation, but you're going to save yourself on the anastomotic leak complications. And that's good, but you still end up with a stoma. So it's a little bit of a halfway house. And then the other halfway house is you just bring out a stoma, and then you can potentially give chemotherapy, and then you can come back and do an operation afterwards. The downside of just bringing out the stoma, unlike a bridge to surgery stent, with a bridge to surgery stent, you can operate basically anytime you want after that. After you've done your stoma, even if you manage a laparoscopic stoma, you still got a waiting time. It's going to be difficult to operate again. Vuyo, your hand is up.
Adam, do we ever stent and give chemotherapy and then operate?
Yes, we have, and we can, but we don't have to. The question is, do you need to give chemotherapy? It's another question entirely, but it's an option. Just looking at the Foxtrot data, if you've got an obstructing tumor, it is just about always a T3 at the very least. So I think you can, there's no problem with giving chemotherapy. There's some issue around some of the biologics. I think Avastin has been associated with tumor perforation. But remember, every patient that's in a palliative stent, they get chemotherapy. So there's no harm in giving chemotherapy per se. It's just, are you going to get benefit? And I think what we'll see is that with things like Foxtrot net coming across, that if you're going to stent, you probably should go ahead and do chemo, because they are usually going to be locally advanced tumors.
Then, because I know this case, can I just also say my thinking of why I actually, as much as I said I wanted to resect her, I would have also wanted to stent her first. I just feel also all the ERAS issues she had the kidney issues. She's had about 10% weight loss. We've got anemia. We could have the time to work on all those things, see if we can get her a bit anabolic, give her some iron. And a creatinine of 90, as much as the lab doesn't flag it, is definitely high for her still, from 148 to 90. So she probably still is in kidney injury.
Yeah, look, I think that, a stent to me is a very nice option in a patient like this. Look, a right-sided stent is often a little bit more difficult. You can't prep the colon nicely. It's difficult to get there. But I think, we also tend to think of this in a very binary fashion. You know, it's like, oh, we're doing a stent or we're not. There's also like, you know, if someone's in a palliative situation, I will sit and spend, you know, 45 minutes trying to get a guide wire through. You'll sort of take the complication because the benefit of a stent, it's such a good palliative solution. Whereas if you're looking at a bridge to surgery, you go and have a look. If the stent's just going to go in and sail in easily, the chance of complications must be much lower. Your manipulation of the tumor is less. So, you know, maybe an easy stent is the way forward, but a low threshold to pull out. Zubair.
So Adam, if we were to stent her, would that change our options in terms of an operation in 2 weeks' time?
No, you could operate, well, I think you'd do a right hemicolectomy and primary anastomosis, you know, but now you're going to be doing it.
Because that's what I would have done either way. So why would I stent and wait 2 weeks? I mean, is she going to benefit that much in that 2 weeks that we're stenting her?
Well, because you've got to look at if you're doing an elective operation versus an emergency operation, what happens with the morbidity. So
Okay.
It's unlikely you're going to manage, for example, to do a laparoscopic operation in this patient. Now we can debate whether there's benefit to laparoscopy or not, but let's say that common opinion, apart from data, says that it's beneficial to do laparoscopic surgery. It's certainly quite nice to get the patient in and out, and there are at the very least some benefits. So it also is an easier operation if you do your bridge to surgery. I mean, you know, it's not dilated bowel, the patient's in better condition, and I think that the patient's generally going to have a better outcome in the short term if they're not acutely obstructed compared to if they were. So, but once again, it's not a binary thing. You know, one person who's got a touch of bowel obstruction versus, anyway, you helped me with that colleague, with our colleague the other day, you know, that diverticular stricture. I mean, you know, it's like a complete nightmare of an operation. So I think large bowel obstruction can be very, very difficult to operate on. And I think that make your life easier generally have a beneficial effect for the patient. But I hear you. I mean, a right hemicolectomy either way with a primary anastomosis. My bias is that the patient with a bridge to surgery stent will do better, but I can't prove that today. What we do know is the patients we do a bridge to surgery stent on, they often have quite a lot of inflammation around that tumor. You know, there's just, it's not an easy dissection there. There certainly is a little bit of, you know, you get the feeling like something's happened there. Any other questions?
Can I complicate the matter?
Yeah.
Sorry. Let's say you have a patient who presents with the right-sided tumor and potentially manageable upfront let's call it upfront resectable liver metastases. I haven't found anything in the literature about stenting those patients. Is there anything that I'm not aware of? And
well, I don't know if there's in the literature, but I can tell you what we would do, because, you know, essentially, if you've got synchronous liver metastases, we're very keen on giving you chemotherapy upfront, even if they're resectable, because we think it gives us an idea of the biology of the tumor. And if you progress on chemotherapy, then you're probably not going to get a resection, even if you remain resectable. So let's say you start off with 2 liver mets and a right-sided lesion. We give you chemotherapy and you end up with 5. We'd probably say, you know, we're not going to cure you with surgery, because it's poor. If you progress on chemotherapy, it's a poor prognostic sign. So I think giving a stent and giving chemotherapy is a very reasonable option. I can't tell you which is right and wrong in these. Nobody knows. What we expect from you in the exams is to be able to have the discussion and say, the pros of stenting are this, the cons of stenting are this, the pros of upfront resection is this, the cons is this, and you're going to balance it to the case. To me, this case, I'm going to do something less aggressive upfront. I would probably go for a stent first, then second, a resection with stoma, third, stoma, and fourth, stoma and anastomosis in this case. But I can't remember the patient per se, and a lot will depend on the eyeball test and how you see the patient. But there are things here that worry me: short of breath, smoker, loss of weight. it's a biggish tumor. We know that the data in the world shows that you can do a primary anastomosis and left side obstruction. I can tell you right now that in this hospital, you cannot do that. It fails every time. So, we're concerned about it. But literally, you can do whatever you want. The data doesn't tell us what to do. There isn't data around. What you need to be able to do is say, these are the pros, these are the cons. This is what I suggest in this patient for these reasons. And it's that in your certificate exam, if you're sitting the South African certificate exam, that's the whole thing is a discussion. We can do this, we can do this, we can do this. This is the advantage, this is the disadvantage. This is what I would do. But essentially, when you say what you could do, most of the time, it doesn't really matter. We want to see your understanding of the issues around it. So what would I do here? I think is a great candidate for a stent, this patient, personally. Any other comments or questions?
She's got a great eyeball test.
She's got a great eyeball test. Okay, well, that counts for a lot, I think it's...
I differ with you.
That's
I think we'll fail the eyeball test.
the other thing with the eyeball test. There's interobserver variability, quite clearly.
Depends on how many disasters you've had. Your eyeball changes.
And there's a study called the Plato Project, I think, which is a study of surgeon personality in an anastomotic leak. I took part in it. They give you a whole lot of scenarios. They ask you like personality type questions and then give you a whole lot of scenarios and see whether you'd anastomose patients tomorrow. Or whether you'd anastomose the patient in the scenario, not tomorrow. That happens when you're trying to read your email and talk at the same time. Any other questions, guys? Got to wrap it up, but we've got a little bit of time. Rufaro, you understand all the concepts. This is fair game for general surgery. The FCS final, right-sided bowel obstruction.
Yes, I do, and thank you. It was quite nice going through the options.
Okay. I'm not going to pick on anyone else. Feel free to shout out. Okay. If that's it, thanks, Zube and Vuyo for putting the talk together. It's quite a nice thing you're on today, Zube. You get Vuyo to do all your talks. And thanks to ECHO, the University of New Mexico, and ECHO India team for the support. There's the feedback forms available in the chat if you want to do that. There's talks are recorded. She's very bored. Thanks to the Gastro Foundation for allowing us this platform. And just next week's talk, for those of you on colorectal, it's Gallbladder, Polyps and Cancer by John Deval. All right, guys, that's it then. Cheers.
Thanks, Adam. Cheers.
Thanks, everyone. Bye-bye.
Thanks, Gert.